May we then now move on, please, to item 6 on the agenda, which is implementing the recommendations of the Francis report on Winterbourne review. And Bill will introduce the paper together with Jane Cummings. Bill?
Thank you, Chairman. Yes, Jane and I share the executive lead on this, but I'll introduce and hand across to Jane. And none of us need reminding that both the Francis report into Mid Staffordshire and the Winterbourne View report highlighted some appalling failures in care, and I think marked a really important stage in us rethinking the way we relate to citizens, to people, to patients in the delivery and the shaping of care and services. We've deliberately brought together our reporting on Francis and Winterbourne View. The reason for that is that there is a risk that the Francis report and the publicity around that crowds out some of the really important lessons from Winterbourne View as well. We believe there's an awful lot of commonality across those two. So in the way we're looking to change services, improve care, we want to keep the lessons from both very close together. And I think the primary lesson is about the culture change that's required in services, better to provide high quality care for all now and for future generations. And indeed, in the way our board has discussed this before and continues to talk about these, we've tried to draw these lessons into the whole of our business plan, not so that we've got a discrete set of actions in one area, but we've tried to use it to inform the whole way we work. And everything Tim was talking about in openness, in engagement, involvement of patients, all of that is central to the sort of culture change that we think is fundamental to really hearing and responding to the lessons of these reports. But we have also committed to undertake a set of specific actions, and we promised previously that we would report on those very openly and transparently, both to the board and to the public in general, and that's what the annexes in this report do. And they set out that we're making progress across the breadth of our commitments. I think I would highlight that, particularly around a number of the Winterbourne View commitments, we've developed an exceptionally strong working relationship, both with local governments, and indeed many of these we're jointly implementing. I should mention Chris Bull, who's an ex-local authority chief executive, who's now working across local government and ourselves to give some real leadership to that, but also actually to the political leadership of Norman Lamb, who's being and continues to be a strong advocate for the lessons of Winterbourne View, and those particular group of people who are disadvantaged can be left out if they don't have someone very publicly voicing their interests, and we've worked very closely with the Minister in this work. It's the message, I think, is a reassuring one for the board, and that we are making progress across all of our commitments, but I wouldn't want to underestimate how much there is still to do. We can undertake a set of actions, but to change the NHS will take longer, but we're absolutely determined, and we're keeping to all of our commitments. Jane may want to pick up more of the specifics or give a particular angle from compassion in practice, which is a key part of this.
I think Bill said a significant amount of what we needed to cover in this report. I think from my point of view, I think there's just a couple of things I'd want to reiterate. One is that this is absolutely about a fundamental change in the way we approach care. So this is about the culture of the NHS more generally. It reinforces the fact that this is about what we are. This is about what we do. This is about our value base. This is about how we change the way in which we both provide care, but also the way we we really concentrate. We actually live the values. We talk about them. It's not just about talk. It's about what happens at the front line. It's about what happens in the way we both commission and support people to do the right thing for our patients. Compassion in practice, which we will come back to at a future board meeting, has been really set up to transform the way nurses, midwives, care staff do what they need to do. But it's also about the values of the 6 Cs that we've talked about in the board meeting before, that are being taken up by all staff in all settings across the NHS, which has been really, really positive for me as I've gone around the country and looked at how people are doing things. In terms of this particular report, I just wanted to highlight the additional work we're doing around Winterbourne View. We have gone a step further, where we are now looking at in quite a lot of detail about the quality of some of the work that's been done. It's not just about ticking the box and saying, yes, we've done it, we've met those recommendations. We have gone back in with an expert in learning disability care, working alongside our stakeholders to assess, has the work that's been done been of a good enough quality? Can we do a deep dive into some of the detailed work? Is there any variation in the way in which this has been done across the country? Can we improve that? Can we make sure that we've really done the best it possibly can be and looked at individual needs for patients? So I think I just really wanted to flag that, but also to highlight that our detailed response to the 290 recommendations that were in Francis will be done in collaboration with our key partners, and we will also look at the Berwick review, we'll look at the Cavendish review, we will look at the work that Tricia Hart and Anne Clwyd have done on complaints when that's published, and we'll also look at reducing the burden of bureaucracy that's also due to be published soon, and we will look at all of those together in terms of our overall response. But I think Bill's said a significant amount of what we wanted to cover, and I'm very happy that between us we can answer any questions that other board members may have.
Thanks, Ben. Perhaps I might kick off. I think that what is common between those two appalling instances, and perhaps most accentuated in Winterbourne View, was the sheer vulnerability of the patients. There was no one there to support them against that very cruel treatment. And all the things that we've discussed this morning are instances where patients have a positive feedback through all the initiatives that Tim has outlined. How can we be sure that where patients are vulnerable, not able to input feedback back into the system, how can we be absolutely sure that they are getting the highest quality care?
I think there are a variety of ways of doing that. If you look at the work we've done on compassion in practice, for example, we've got 6 different areas of action. And within those areas of action, I would highlight a couple of them. One is around the patient experience, and we've heard a lot about FFT. One of the pieces of work we're doing at the moment with the patient experience domain is how we can ensure that those most vulnerable people who may find it difficult to answer the FFT type question can have their voices heard. So Neil Churchill, who's a director of patient experience, who leads work on improving patient experience, is spending time currently looking at how we can truly access the sort of real feedback that the most vulnerable give, those with dementia, those with learning disability, those children and young people who find it more difficult to answer the FFT. So we're looking at that. The second area that I wanted to highlight is the action that looks at measuring impact of care. So how do we measure the things that really matter? How do we demonstrate how we're making improvements in terms of true measures of quality that may include for our patients things like falls, pressure ulcers, healthcare associated infections, looking at those sorts of things together. The next area is how do we build and strengthen the leadership of our staff so that they are in a position where they can lead those services, they can feed back, they have the time and the scope to be able to really spend concentrated effort with patients and understand what's happening on a day-by-day basis. And then the other one I wanted to really highlight is our staff experience. If you listen to staff and you listen to patients, we understand so much better about what's going on. And asking staff whether the area they work in is one that they would want their loved ones to be cared for, whether they feel that they're giving good quality care, and they're able to give the quality of care they feel is deserved or needed by patients, And second and lastly, whether they would recommend that place as somewhere as a place to work speaks volumes about care. And we need to. It's not one simple issue. We need to build those things together in order to really tell the story, hold the mirror up, and say, is this care good? Do our patients say it's good? What do our patients say we need to do? And we need to do that at a level that is detailed enough for individual wards, and in some cases individual shift by shift, whether that be in hospital or out in the community, is absolutely key. So there's a lot of work we're doing to try and pull that together. Certainly Compassion in Practice is driving a lot of that, but we need to think about, and we are thinking about, this is not just about nursing, midwifery and care staff. This is about the whole team. This is about doctors, it's about AHPs, it's about the reception staff in GP surgeries. It's about looking at everybody in terms of how we ensure that care is the best it possibly can be.
Thank you. I mean, these were not occasional acts. These were instances of institutionalised cruelty, which we would never have believed could have occurred in the NHS. We cannot be complacent ever again about that. I mean, it's just so essential to ensure that there is no repetition of what we saw in those two instances. So I'm reassured by this, but we will, as a board, seek constant reassurance that nothing escapes our overview of what needs to occur. I've got Bill and Victor to come in, please.
Thanks. I say, in response to your question, I think the greatest risk, which has been there over the years, is this out of sight, out of mind with some of the most vulnerable people. We're talking about around about 1,300 people who have been in inpatient beds for learning disability or autism. That's not a huge number when divided across the 200 plus clinical commissioning groups. And what we're trying to do through this programme is not have them, if you like, on the end of an annual commissioning decision, but to be in a continuing relationship with them, with their families, with carers, of support and oversight of the conditions, and continuing to make sure that they're getting the right care that best suits them in the right environment. So this is, the enemy here is out of sight, out of mind. So the visibility of, knowing who those people are all the time, understanding their situations, working with their families and themselves to describe what will best suit them is absolutely key. That ongoing relationship is the heart of what we need to do with those most vulnerable people. Victor.
Two things. The first is, while I welcome everything that's been said to date, I think Malcolm's point goes to the heart of the issue. It's communicating with a number of people with learning disabilities and dementia and other is about our understanding of the nature of their communication difficulties. Because if you look at these cases of continuous abuse, they fed on the fact that these individuals could not communicate, and there was no means by which the system could communicate with them. So there's two things. One is, I'm interested in what work we're doing with organisations outside the NHS family. I'm aware that in the not-for-profit world there is a collection of organisations that are focused on Winterbourne View and the response and how that changes culture and communication in a systematic way. And I think we should understand that. And I know I'm not expecting that we should all have, a year's training in Makaton, but we should understand how we're communicating with those people as much as we understand how we're communicating with people who haven't got learning disabilities or who speak English or don't speak English for that matter. So I'm interested in I think we should understand a bit more about what is the basic methodology of communication that we're using, and secondly, how we're working across the piece with organisations that are outside our immediate purview, but for whom these people have day-to-day contact with organisations in the not-for-profit sector, organisations in the private sector, etc., and whether we can sort of build a much more joined up consensus as to what should be happening, how we know it's happening, and how these people can be given a voice into deciding what should happen.
I can start, and I think then Tim might want to talk a bit more about in terms of the work that his team are doing around patient and public engagement. I think you make really good points, Victor, and I think that I think we need to be upfront about this. That we still need to do more. Certainly, in my team, we've literally just appointed the head of mental health and learning disability, and so it took us some time to get the right person appointed to that. And Neil Churchill has just literally in the last couple of weeks completed his team. And within that, he's also got somebody with a specific responsibility around mental health and learning disability. I think what is very clear from the work that Neil and others have done is that he has spent a considerable amount of time engaging with other sectors, third sector, charitable sector, voluntary sector, and I think we will start to see the benefits of that work over the next few months. But we have got further to go. There's absolutely no doubt about that, and we need to ensure that we concentrate on actually being able to communicate best with those most vulnerable and those that can't in the way that we would otherwise do. So in the past I have learnt Makaton. Whether I can still do it, I'm not sure. But I do think that we need to think differently, and I do think we need to come back to this and be able to assure you in more detail in the future. But I know that Tim's team have also got a significant amount of work around engaging, so he might want to add to that.
Yeah, so, very quickly, I mentioned the Citizens' Assembly, and of course, Victor, you're leading on that, so I think that will have a very important role to play in bringing together so, you're so right to say that the NHS has under-exploited the incredible value of third sector, other partners, and frankly also private sector partners in delivering innovative new ways of having better conversations with people with learning disabilities, but also just to empower them to be able to speak more clearly to us as well, in a sense. So there's that. I think just to say, we're publishing, as we're statutorily required to do, guidance to the commissioning system as a whole, of course, including us, on how best to improve the proper degree of participation that they're promoting in development of their commissioning plans. So in there are a whole variety of different, I won't go through them all now, a variety of different standards we're setting for how we believe people will have to work much harder on collaborative engagement with organisations in other sectors altogether. So I think there's a lot of work going on. I'd be very happy to bring back to the board more details on that at some point soon. But there is a lot going on.
Okay, well, I think the board will want to keep this under continuous review. Kieran?
I think I can see the work we're doing at the system level and transparency and all of that. And I think I can see the work we're doing through professions. But we keep talking about we've got three layers of defence. There's boards of trusts. So what are we doing to encourage CCGs to bounce into their local provider and say, are you, as the governance of this organisation, what are we doing about talking to the TDA? What are we doing about talking to Monitor, saying we have an expectation that you're part of this as well? That middle layer I'm not hearing.
Well, that's what the guidance is. So the guidance specifically is describing the standard which we legally are required to set, and then through assurance to make sure it's delivered for CCGs and ourselves as direct commissioners in relation to participation and engagement. So specifically saying to boards of CCGs and to area teams ourselves what standards we think are those that need to be achieved in relation to this. So we're about to publish that. And that will hopefully at least provide a kind of a baseline against which people can judge how to do better on collaborative engagement across the piece, not just in relation to this. So that covers all sorts of things like partnership working, as well as raising new standards around personal care planning, which I think will be another route to it. Am I getting your point?
It would be great guidance, but how do we know that the board of a particular trust in any town actually has read it and is actually making sure that they're worrying about this?
Well, if they're a CCG, we go in and assure them on the basis of it, so that'll be published, and we have a duty to assure if they're a CCG. Now, if they're a provider trust, I agree that's an issue. I do not have a mandate to go and tell a hospital trust. We can tell them what we think is good practice, but I don't have a mandate to enforce it other than through commissioning. But I personally believe that this is about commissioning, and I think it'll be really important for us and for CCGs when they approach their commissioning strategies to recognise that outcomes also include the degree to which people are actively engaging, actively encouraging participation. That is our principal lever.
Okay, well, thank you very much. Jane, did you want to add to that?
I just think, I mean, Kieran's made a really good point. I just, in very briefly, one of the things, there's two things that I can do. One is that I've got as a Chief Nursing Officer for England, I've got a professional leadership responsibility and role with all nurses and midwives, including those that work in providers. So I do get invited in, and I do go and visit and spend time, and we have through the 6Cs Live website the ability to actually look at that best practice, as well as supporting CCGs to be able to do that through their commissioning role. The other thing I do is I chair a federation of nurse leaders. So I chair a group which includes the nurse leaders in Health Education England, in Public Health England, in the Department of Health, in NTDA, as well as through NHS England's route. And through that, we have the ability to work with and alongside those professional leads in places like CQC Monitor and all of the other arm's length bodies. And that we have found has been a really powerful way of not only talking to each other but sharing practice and understanding what some of those regulators are also doing with their organisations, many of which are providers.
Okay, Francis was a wake-up call to the system, and I think we want to make sure the system doesn't go back to sleep. So we will continue to monitor this very closely from the board.